So today's speaker is Keith Horvath. He's an associate professor at San Diego State University and is heavily involved in the CFAR here at San Diego. And he will be talking about his research that primarily focuses on developing and testing HIV prevention and treatment, mobile health interventions. And most of them, I believe, are tailored towards sexual and gender minorities. He is actively involved in the Adolescent Medicine Trials Network for HIV/AIDS interventions, where he leads several studies addressing ART adherence among HIV-positive youth and HIV risk reduction among HIV-negative, transgender, and non-binary youth. His interventions are quite theoretically grounded and have a lot of various components that have been shown to be efficacious, and I'm looking forward to his presentation this morning.
Great. Well, thank you, Jessica. I really appreciate that kind introduction. And I just want to say, first of all, thanks to all of you for being here. I realize that being on another Zoom call, especially at the end of the week of the International AIDS Conference, can be a little daunting. So I appreciate your attendance and willingness to be here today. I just want to check in. Can everybody hear me?
Yes.
Okay, perfect. Okay, sounds good. And certainly, if you have questions, I'm happy to field those, whether they're critical or just feel like it's something that would be timely. I'm happy to take those as well. So as Jessica, you noted, I'll be talking today about the use of mHealth to address the HIV continuum with sexual and gender minorities. So that is definitely sort of the focus of my work, although there are some notable exceptions to that. So just first off, I have no actual or potential conflicts with in relation to this presentation. And I just wanted to acknowledge, I think, Jessica, you noted here just a second ago that there are a number of really amazing member institutions to the CFAR, the San Diego CFAR, that I know many of you are involved with. But I just want to extend our excitement and a welcome to San Diego State University as now being a member institution of the San Diego CFAR. So we're really excited about the potential to sort of collaborate and work with the amazing folks at other institutions that are part of that CFAR. And I, of course, want to extend a big thank you to all of the people that I've worked with, and certainly this is not exhaustive, but the folks at the San Diego State research team that I have here, as well as in my prior institution at the University of Minnesota, a lot of the amazing people that I work with at the Adolescent Trials Network, and of course other folks who have really informed my research program throughout the years. So today, what I really want to sort of focus on is the sort of intersection of three areas. So those include sexual and gender minority health, HIV research, and then, of course, eHealth and mHealth. So I think that an important place to start is, how do we define sexual and gender minorities? So this definition comes straight from NIH. So they define SGM populations that include, but are not limited to, individuals who identify as lesbian, gay, bisexual, asexual, transgender, two-spirit, queer, and or intersex. But importantly, as you see here in red, it's important to note that these populations also encompass those who do not self-identify with one of these terms. And so those, this broad definition can characterize people who have non-binary constructs of sexual orientation, gender, and or sex. So certainly it is it's a quite broad definition, but I also think that there is good evidence that these communities are impacted disproportionately by HIV and other health outcomes, and so it's important to include, have that broad umbrella. And of course, when we think about the NIH strategic plan that is currently sort of in effect, the kind of goals that NIH has are one, to include or to expand the knowledge base of SGM health and well-being through NIH-supported research. Of course, we want to remove barriers to planning and conducting this sort of research. We want to increase the number of researchers and scholars who are conducting SGM research. And finally, they want to evaluate progress in advancing this type of research. And they do it in a number of different ways. So that can include increasing funding opportunities for SGM workshops, having workshops in town halls, holding trainings, providing technical assistance, having specific award programs for SGM research, and then, of course, tracking the amount of research dollars that are going to this type of work. And so when we look at the amount of dollars that are in fact going to both SGM and LGBT research, that certainly has increased. So since 2015, it was $162 million that were allocated to SGM and LGBT research, and that number has pretty dramatically increased to $308 million in 2019, with a projected slight decrease in 2020. This is, of course, you really can't address SGM research without talking about HIV. So as all of you know, the End the HIV Epidemic plan is what has been sort of driving a lot of the funding and interest in HIV research for the past few years. It certainly has the goal of reducing the number of new HIV infections by 75% in 5 years and 90% in 10 years. To do so, they are focusing, or communities are sort of focusing on the 48 highest burden counties, including, that includes sort of Washington, D.C., San Juan, Puerto Rico, and of course the 7 states where HIV is really a disproportionate, and those are typically in the Southeast. And so San Diego County is certainly in one of the 48 highest burden counties. And they want to do this in a variety of ways, right? So there are different approaches that we're taking includes things like testing for HIV and increasing the number of people who are aware of HIV to 95%. A big push in prevention, of course, is biomedical interventions, especially PrEP. And right now we know that of the people who would benefit from PrEP, only 18% have a prescription. We want a target of 50%. And then the perennial problem of people who know they have HIV and are on treatment but are virally unsuppressed, that is still quite lower than we want it to be, with a target eventually of 95% coverage. So here are the priorities that were put out by NIH as far as HIV/AIDS research priorities. Just notice that none of the priorities listed here are specifically for social and behavioral research. Rather, they have to do with sort of increasing or developing safe and effective vaccines and microbicides, developing the next generation of therapies, hopefully at some point developing a cure for HIV, and then reducing comorbidities and co-infections related to it. So it really sort of is on us, those of us who are doing behavioral research, to be able to sort of frame the work that we're doing in the service of one of these 4 priority areas. And so that could sort of happen in multiple ways. And this, again, comes from NIH. So for example, we could develop effective behavioral interventions to achieve uptake of HIV prevention and treatment strategies, as well as reduce health disparities, which of course has been a pretty major goal of ours for many years. More and more folks are focusing, including myself, sort of thinking about implementation research and how can we sort of roll in some implementation research, at least aims within the grants that we're putting up, to be able to sort of look at how can we scale up some of these interventions And then, of course, we want to expand research that examines health and social issues. But importantly, NIH really talks about how these really need to be clearly linked with HIV. And so the last sort of intersecting topic is around e-health and mHealth. And in terms of a broad sort of umbrella term, e-health really is the use of information and communications technology in support of health and health-related fields. There is sort of a conceptual framework that you see here on the left-hand side that talks about all of the ways that we can use e-health to improve health outcomes. And it's quite broad, as you'll see here in a moment, in terms of what kind of areas e-health and mHealth can really impact. But certainly, I'll be talking mostly today about the subset of e-health, as referred to mHealth, which is really the use of mobile wireless technologies for health. So the idea is to put the power of interventions and timely interventions into the hands of those who would most benefit from it. So mHealth is something that I'll be focusing on for the rest of the presentation. There are lots of applications of mHealth and other technology-based applications. I'll focus here on the first one, client education and behavior change. That's something that sort of is the focus of my research, but I definitely want to make the point that there are a lot of different sort of avenues or resources that we can sort of apply mHealth and tech-based solutions to improve overall health. That could include sensors and point-of-care diagnostics, using sort of online data collection and reporting, certainly tapping into electronic health records. But it also includes, if you see on the right-hand side here, sort of more systematic or systemic sort of ways that we can use e-health and mHealth. For example, like doing provider work planning and scheduling to sort of make those processes more efficient. We can also certainly conduct provider training and education, and then even look at things like supply chain management. I think it would be hard not to have a conversation right now, at least to acknowledge the impact of COVID on research. AIDS and Behavior, which is a very common journal for behavioral and social science in our field, they've been publishing a number of COVID-related articles, and fortunately been doing it in a very rapid way. And a lot of those articles, of course, look at the impact of COVID on HIV vulnerable communities. So if you're interested, you might want to check that out. But what I've assembled here is sort of articles on the impact of COVID on research. And so as you can see, a lot of us have had to sort of scramble to figure out how can we continue to conduct important research in the era of COVID. So there's sort of a growing list of different research papers to address this. And they've identified, I sort of read through these, and I was looking for sort of research challenges that are posed by COVID that I think all of us have to kind of consider at this point. So that includes participants are facing increasing mental health, substance use, and financial hardships. And especially when you think about, for example, the impact of COVID on interpersonal violence that may occur because we are at home more often and there are more opportunities for that. So that's a genuine issue. Participants may not have access to technology, or they may not simply have the technology skills in order to navigate some of the things that we are asking them to do. Also, participants may not be able to receive electronic payments. So we know that a lot of our communities rely sometimes on cash payments, but in the era of COVID, we may have to sort of send electronic payments. And how do we do that if they, for example, may not have bank accounts or other sort of financial barriers? Participants may not have a safe place to receive packages and mails, or they may have limited privacy options. So imagine, for example, a transgender youth that is enrolled in your project. That youth may be living at home with parents who are not aware of their transgender or non-binary status. So that may not be a safe place, for example, to send packages like STI kits or other sort of home collection biomedical sort of data or packages. And then they may have limited privacy options. So on one of our studies, we have e-coaching, and I'll describe that later. We have an e-coaching component that requires kind of Zoom and using tele-video conferencing. Well, they may not have a space in their house to actually carry that out. Participants, verifying participant identity has always been a major issue, especially in online studies, but it certainly might be heightened with COVID. And then does your staff actually have the training and the skills to conduct remote assessment and intervention? And then finally, there are all sorts of ethics and related issues related to remote assessment and intervention. So, so those are definitely some of the challenges we face when we think about how we conduct rigorous HIV-related SGM health research using eHealth and mHealth. And of course, our goal is to sort of find that sweet spot in the middle that both reviewers will really respond to and that we can have the greatest impact. So I'll spend the rest of the time today just talking about 3 ways that mHealth can enhance SGM HIV research. And the 3 things I'll focus on are 1, providing real-time tailored interventions. 2nd, addressing syndemic factors among sexual and gender minorities. And then 3, how can we use it to reduce costs of intervention development? Okay, so I'll focus first on providing real-time tailored interventions. So tailoring can occur on multiple levels. We can think about tailoring content and features, but we can also think about tailoring entire intervention approaches. So I'll focus first on how do we sort of tailor content and features. So in order to sort of really understand what our users and our communities need, we often will go to those communities and specifically ask them either to reflect on what their needs are, or in many cases, we might have some, for example, mock-ups or study designs, intervention designs that we can actually show them and be able to sort of get their opinions and reflections on those, and then we can adapt to those. So that's exactly what we did with the Youth Thrive study. So the Youth Thrive study is part of the Adolescent Trials Network. It is the only study, at least in our circle of iTech, that is focusing on HIV positive youth. And so what we did is we took a pre-existing mHealth intervention called Thrive With Me, which was in the field at the time. And we, so we already had developed that, and that intervention was for HIV positive adult men who had sex with men living in New York City. And you can see a screenshot of what Thrive With Me looked like. What we did is we took that, the screenshots from that intervention, and we actually conducted 6 focus groups with youth living with HIV, where they were shown those screenshots and then asked them for feedback. And we conducted those focus groups in Houston, New York, and Chicago. There were 3 focus groups with younger adolescents and 3 focus groups with older adolescents. And so what we did is we used the information that we obtained from what they told us, what they liked about it, what they didn't like about it, what they would change about it. And we made some pretty dramatic changes to the interface and the content, which again, I'll talk a little bit about later in the talk today. But what I wanted to use that just as a backdrop for is we used the information from what we learned from the focus group, and we combined it with focus group information from 4 other studies in the Adolescent Trials Network. So that includes Text Step, which I'll talk about later. That's a study I'm involved with that is with trans and non-binary youth who are HIV negative. And then My Choices, Links, and P3 are all adolescent trials network studies that are specifically for HIV negative, primarily men who have sex with men who are adolescent or young adult. So we looked at common findings across these different studies, and here are some of the results. We have four sort of overall common themes. One is to protect our privacy and help us avoid stigma. So youth were pretty much across the board very sensitive to the fact that these kinds of mHealth interventions, whether it's a native mobile app or a web app that's designed to sort of display on your phone, they were worried about sort of how are we going to protect their privacy. So that could include multiple privacy protections, like having passwords or using fingerprints to allow access to the intervention. They really did not like the idea of logging in through existing platforms like Facebook or Twitter. They just felt like that, I think that connection to sort of how they're using these other widely available programs and sort of access to this sort of standalone intervention, that was something that they did not necessarily want a connection between. And then just importantly, stigma was consistently discussed and related to keeping HIV status, sexual orientation, and sexual behavior really confidential. So they really sort of had a very tight conceptual thoughts around sort of privacy and stigma. One thing that, of course, shouldn't surprise any of us is they really wanted to see diversity and their identities reflected in our interventions. So this includes having imagery that should be discrete but representative of individuals in our communities. They wanted sort of this diversity reflected through positive themes, motivational language, and humor, right? I think so many of the communities that are impacted by HIV, all they hear is negative. And so we really have to sort of find ways to ensure that they can sort of hear and see positive role models on our interventions. And then, of course, they wanted this diversity reflected in texts and videos and imagery throughout the interventions. Okay, a few other here. They really appreciated this idea of being able to engage with the intervention in multiple ways. So just in terms of the look and the feel, they were most comfortable with sort of existing platforms. And again, they didn't want the connection between those platforms, but what they really liked is this idea of being able to sort of have a platform that felt familiar to them. So that includes like Snapchat and Instagram and Facebook. So kind of as we design our interventions, maybe looking to those applications and seeing what elements we want to draw from. Youth also wanted to be engaged through a lot of different things like gamification features, messaging functions, like not only to other participants, but also being able to contact study staff or clinician support through the actual platform to receive that support. And then finally, you said that they just wanted more expansive content. So they wanted to see examples of successful role models in their interventions. And they wanted the interventions to also address not just HIV, but more holistic health. And so I think oftentimes youth and affected communities can really feel like there's so much negative sort of focus on only HIV, but really trying to motivate them by thinking about how HIV and testing and all these things we're asking them to do fits into a more holistic health model would be something that would motivate them. So these were the common sort of features when we think about sort of the content and the features that we should start to think about if we are developing these kinds of resources for youth. And of course, that might change depending on if we're talking about working with older folks or different communities. Okay, so that is thinking about tailoring on features and content, but we can also tailor on whole intervention approaches. So an example of that is a study that my colleagues and I published last year. It was on a project called Project Moxie. We recruited 202 trans and non-binary youth, and we gave them and randomized them in a 2-to-1 fashion to two groups. One was a home-based HIV testing component, and that was coupled with a video chat counseling. So a youth would sort of log on to a video platform with the counselor. The counselor would do some pre-testing. Then the youth would actually do the testing during the counseling session, and then there would be post-testing or linkage to care, depending on the outcome of that testing. It drew from motivational interviewing and problem-solving approaches. And then the control group, again, was randomized to a 2-to-1 in a 2-to-1 way, with one being the control group. They just received the home-based self-testing alone and were asked to self-test. So we had data at baseline, 3, and 6 months. And what was really interesting about this is that when you look at the control participants, the 76 that were randomized to the control condition, all 76 completed the intervention. Now contrast that with the intervention group, where of course we had more in it by design, but less than half of the intervention group completed the intervention. Now, of those folks who completed the intervention, there were very high acceptability ratings. So 90% would repeat the session, 81% would recommend the session to a friend, and then 98% would recommend HIV self-testing. So high acceptability among the people who completed the intervention. So what were participants who did not complete the intervention worried about? Well, they were primarily worried about having to be seen physically on camera by a person who they really didn't know. And so this led us to believe that we really had two groups of youth. Those who wanted to test themselves at home and benefited from access to ordering HIV self-testing kits. So you can imagine that these are folks who really need minimal support, and you can send them an HIV self-testing kit and have them complete that successfully. And then there were a group of youth who wanted the opportunity to talk to a counselor via video chat. So you can imagine, in terms of tailoring whole intervention approaches in future iterations of this, you could provide trans and non-binary youth with a menu of different options. Those options could include multiple formats, like you could have, for example, a format where you have just home testing alone versus home testing with counseling, like we did in Moxie. But you could also have, for example, an option where you could send a home test and then you could provide youth with a bank of videos. They could be how-to videos, they could be first-person testimonials, that kind of thing, where they might actually benefit because they don't want to necessarily get on a call with somebody face-to-face. So different ways to think about tailoring whole intervention approaches. And we actually have a grant proposal that'll be reviewed next week that kind of follows up on this. One thing we can also think about is matching the intervention intensity to the needs of SGM youth. So this was done in TechStep. As I mentioned, this is an adolescent trials network for HIV negative, transgender and non-binary youth. And what we're doing is we are randomizing them to 3 different groups at the very beginning. It's just sort of a very basic website control intervention that youth have access to. The second is a text message intervention that is developed by Kathy Reback at UCLA and Friends Institute, based off of her previous work. And then our team developed a mobile web app, which is basically a website that's optimized for smartphones so that it looks sort of in looks and feels like a native app, but it doesn't have some of the capabilities that native apps have. And then for youth who are randomized to either the text message intervention or the web app intervention at month 3, then they could be re-randomized in a 2-to-1 fashion to receive the original intervention plus e-coaching, which is quite a bit more intense. It's an 8-session e-coaching intervention, or they could be randomized to stay in that intervention. So here is just a sort of complicated design approach that you can kind of see for text step. So folks come in here at the beginning and they're randomized to one of these 3 groups: the text messaging only, web app, or a standard of care, which is just basically a website. Then at month 3, people who are responding to the intervention just continue on in that condition. Folks who are non-responders at 3-month evaluation are then re-randomized in a 2-to-1 fashion to either stay in that intervention or they receive that original intervention plus e-coaching for 3 months. And the same with the web app. Their non-responders are re-randomized, and then they're followed at months 6 and 9. So the interesting thing about looking at this kind of approach, sort of stepped care approach, is you can really start to look at whether or not youth who are not responding to a lower intensity intervention will then, of course, respond much more effectively to more intensity. So you can sort of ultimately compare, of course, the main effects of each of the 3 conditions that they originally randomized to, but you can also do things like take a look at, whether receiving additional e-coaching on top of everything else, whether that is more effective than just receiving the original text messaging or web app intervention by itself. And then you can do things like look at whether or not the control condition fared equally or worse than, for example, receiving the package of interventions that includes the text messaging, app, and e-coaching. So a lot of really interesting and important, I think, questions can be answered from this approach once it's all done. Okay, so that was talking about real-time tailored interventions. The second thing I want to sort of mention is this idea that we can use mHealth to address syndemic factors like mental health and substance use among sexual and gender minorities. So a lot of you are very familiar with and know the literature around syndemics. So you'll recall that Ron Stahl and his colleagues now quite a few years ago published a paper where they sort of coined the term syndemics, which is co-occurring individual level health problems like child sexual abuse and mental health symptoms that interact with each other to increase risk. And of course, what they found is that persons who with increased numbers of psychosocial health problems, those were the folks sort of as you sort of piled on the number of psychosocial health problems that had higher risk sex and also higher HIV prevalence. And so the idea that we can think about sort of the multiplicative effect of these different psychosocial health problems as an important driver of HIV infections is important. And so our team recently, I think it was published last year, or maybe it was published this year. David Pantalone led this effort, but we had some amazing folks like Kimberly Nelson and Abby Batchelder on it. We conducted a systematic review and meta-analysis of combined behavioral interventions co-targeting psychosocial syndemics and HIV-related health behaviors for sexual minority men. And that was, this systematic review was done in the past 20 years. So what we did is, for the inclusion criteria, we said the intervention had to target both at least one syndemic factor, such as like mental health or substance use, and it had to co-target some kind of HIV related behavior like sexual risk reduction or ART adherence or engagement in HIV care. And so, as you can see here, we started out with a lot of different articles identified through database and through a series of exclusions. We essentially narrowed it down to 43 articles that reported the results of 44 intervention trials. My colleague and good friend Adam Carrico had one study where he reported 2 different trials in one paper. And so this is what we found. These categories, by the way, are not mutually exclusive, so just be aware of that. What we found is that the most common syndemic and HIV pairings included drug use and sexual risk behavior at 52%, mental health and sexual risk behavior at 36%, and alcohol use and sexual risk behavior at 34%. But then you kind of see the next groupings of syndemic pairings include basically the syndemic outcome of either mental health, drug use, and alcohol use, and ART adherence. In terms of looking at missed healthcare appointments, I actually think this is the same study, but that same study looked at both drug use and mental health, so not very many around engagement and care. So here's just briefly what we found was that there was evidence through our meta-analysis that the RCTs had a small but significant effect on improving syndemic outcomes. So again, that was primarily mental health, substance use, that sort of thing. And then the effect size was smaller, but still significant for health behaviors. So overall, the interventions did have a positive impact on those HIV-related health behaviors, such as reducing sexual risk, improving ART adherence. Okay. And then what we found in the systematic review, and certainly this will change, I think, pretty dramatically in the next few years, we only found 2 technology-based interventions, and those interventions were both targeting alcohol use and sexual risk. And then depending on how tailoring is defined, about 1/3 to 2/3 interventions were specifically tailored for sexual minority men. And that tailoring could occur in a variety of ways, like having psychoeducational content, strategies, and examples that specifically referenced and reflected the experience of sexual minority men. There were also studies that were tailored in the sense that they use SSM or SMM specific theories or models. Some studies were adapted from prior interventions that were focused on sexual minority men. And then a number of studies use formative research like focus groups to inform their interventions, and those focus groups were done with sexual minority men. So I just want to give an example of sort of then how we can use mHealth to address syndemic factors. So one effort that we just got funded for last year is my friends and colleagues, Adam Carrico and Sabina Hirschfield, we got funded through NIDA to basically develop a mobile app to improve ART adherence among stimulant-using HIV positive men who had sex with men. So where this came from is that I had a small pilot study called AB+, which was a basic ART adherence sort of intervention with some self-monitoring features, some tailored information, and so forth. And then Adam Carrico had I would say, a much more rigorously tested intervention called Artemis, and that was a positive affect intervention. So I'll talk about how we're sort of combining these 2 interventions here in order to develop this mobile app. So with the App Plus pilot trial, again, this was a mobile app intervention for Android and iOS to improve medication adherence among stimulant-using men who had sex with men. It included tailored information, ART, adherence, self-monitoring, and feedback. And then we had this sort of choose your own adventure where we had a fictional character and people could kind of read a snippet of the text or the story and then choose which way they wanted to go. And then interwoven in that was some information about how to address specific adherence barriers in that. It was pilot tested with 90 HIV positive stimulant using MSM between August 2016 and 2017. And they were sort of randomly assigned to the @+ intervention or no treatment control. And just real briefly on the outcomes, what we found on the left-hand side, you see the self-reported 30-day adherence at baseline, month 2, 4, and 6. Note that at month 4 is when the active intervention period ended, and so month 6 is really looking at sustained effects. In the solid black line, you'll see the intervention group, and then in that sort of very fine dotted line, more towards the bottom, that is the control group. So you can see that at month 4, there's a fairly large difference between the intervention and control group in terms of self-reported adherence. And then in that sort of dashed and dotted line, you see that those include the intervention participants who actually downloaded the app and used it. So again, you still see a pretty dramatic differences at month 4. Unfortunately, those once you took away the app, those differences disappeared, which is unfortunately quite common. On the right-hand side, you see recent stimulant use. We did not specifically target or ask men to reduce their stimulant use, but you see that across the board for both groups, stimulant use declined over time. It just so happened for the intervention group that stimulant use declined over time much more quickly than in the control group. So then there's the Artemis intervention, which is an in-person intervention developed based off the work of Judy Moskowitz and led by Dr. Adam Carrico. And in this intervention, they were really focused on trying to improve issues around positive affect for stimulant using or methamphetamine using MSM. So the kinds of intervention components included noticing positive effects, capitalizing on positive effects, increasing gratitude and mindfulness, having men sort of more positively reappraise situations that they run into their life, building off their strengths, helping them attain and achieve attainable goals, and then of course increasing altruism. So we published this paper again, I think last year on this intervention and found some exciting results. So by month 15, you'll notice that the Artemis group, a much lower percentage of them had any unsuppressed HIV viral load across 15 months compared to the attention control condition. And then when you look at stimulant use across time, the Artemis intervention, a much lower percentage of men in the Artemis intervention had a reactive urine toxicology for stimulants than the attention control. So this is kind of what we're doing. So we have this intervention called START, Supporting Treatment Adherence for Resilience and Thriving Study. It's based in part on the information, motivation, and behavioral skills model, but sort of really interfuses with that or introduces to that this idea of positive affect, which will hopefully sort of improve relevant information and motivation and skills to deal with sort of life stressors. And that's, of course, we're hoping that that will ultimately improve ART adherence and address and reduce stimulant use, all in the service of hopefully improving viral suppression. And obviously, I'm not going to go through this whole thing, but you can see here are the different components of the @+ intervention and Artemis, and we're going to kind of take, and right now exactly what we're trying to do, sort of take these different components and merge them into one mobile app where we can sort of have a semi-structured way of leading guys through these different parts of the Artemis intervention and taking a lot of the self-monitoring components from @+ and creating one mobile app that we will sort of be recruiting men nationally and hopefully engaging with them, and then collecting a lot of our biological data remotely as well, which was planned before COVID, but is now even more relevant. Okay, so that's just an example of how you can sort of address syndemic factors using mHealth applications. So the last thing I want to talk about here is how can we reduce cost of interventions using mHealth? Because this is increasingly, we have, as we all know, we've always had sort of a lag in terms of financial resources and what we would like to accomplish. And mHealth can certainly work towards improving that balance. So we know that tailoring is important. There's evidence that tailoring interventions to individuals and contexts is associated with improved outcomes. Although if we can get into it, there are some nuances with that, and the data aren't always consistent on that. However, tailoring can be quite expensive if we're tailoring for each new community and outcome if they need their own unique intervention. So part of what we've been doing in our lab is, using this idea of don't reinvent the wheel. So one thing that we can do is we can take a similar platform and sort of adapt them for different groups and health outcomes. So remember that the platform that you are developing with any sort of mHealth intervention is not only sort of the user-facing platform, right? What the users see, so the features and the content and the layout and the design, but there's also on the other side, this whole back-end system that as researchers we have to access that collects all the data about how people are using the intervention, and also allows us to actually manage participants in the intervention. And so those are the kinds of things that we can repurpose a lot of the code so that we can reduce the cost of those. And we've done this across multiple studies that you see here. And in fact, I can add to this study. I currently have a study with Jamila Stockman at UCSD, where we are developing an mHealth intervention for African-American women with HIV. And so we're in the process of taking, again, our similar sort of platform and really adapting it for that particular community. So we started out with a Thrive With Me study, which was for HIV positive adult MSM to reduce their viral load. Then we adapted it for youth living with HIV as part of the Adolescent Trials Network, again, to address adherence and viral load issues. And then we also use it to adapt it for HIV negative transgender and non-binary youth who are HIV negative to increase or to decrease condomless sex and increase PrEP uptake and use. So here's how we sort of did it. So we started with Thrive With Me. The kind of components in this intervention were a private social network where it's kind of like Facebook, where people could interact with each other and post comments and react. Plus we had tailored HIV and ART information, daily text message reminders, adherence self-monitoring and reflection, and some gamification components, which primarily were sort of leaderboards and micro leaderboards, but it wasn't really tied to any new features of this study, or they didn't get any sort of monetary reimbursement if they were, for example, high on their leaderboard. It was purely for intrinsic motivation purposes. So then we took that same platform and we showed, as you heard before, we showed youth the screenshots of the adult version of Thrive With Me and said, what do you like, what you don't like, what would you change? And here's what we ended up with. We kept the private social network feature. We kept the tailored HIV and ART adherence information, although we pretty much had to rewrite all of that to be more youth friendly. Instead of having a daily text message, youth said that they hate that idea. And so we now have a weekly text message engagement reminder. We have in-app notifications, still continue to do adherence and mood self-monitoring, but we now have a goal setting component of it. And we really created gamification components that unlock certain features of the app, like different backgrounds and ways that they can post color backgrounds that they can when they post messages. So we tried to tie it to something that they could gain. And then we used that same platform and showed trans and non-binary youth different screenshots from both Thrive With Me and Youth Thrive and asked them to reflect on that. And you can see that we made some additional changes. So we kept the private social network, but now we had to change our tailored information to now reflect PrEP. We have weekly engagement text messages that we kept. We kept the in-app notifications. But we allow now people to self-monitor. We recommend self-monitoring PrEP, sex, and hormones, but they can really create any custom tracking that they want to. We now have a trans resource locator. So it sort of works like Yelp for different resources for trans youth. And they can sort of search those and then comment on those and rate those resources. And then we, of course, kept the gamification components that unlock different features. But you'll notice in each of the 3 steps, it's not only the features that change, but just when you look at the actual interface, they're all 3 quite different. So we're really trying to be responsive to the communities that we're trying to serve. Okay, so I just have a few minutes left here. So just a few final thoughts. So in 2012, Whitaker and his colleagues did a study where they asked experts who were in the mHealth arena what kind of challenges they would face in terms of implementing mHealth interventions. And here's what they sort of came up with. And as you can see, there's quite a few. Some related to policy and regulation and regulatory challenges, like how do we deal with privacy and data security and FDA regulations. So some apps that dispense medical advice are FDA regulated. None of ours are, but that's certainly a possibility. How do we deal with the challenges of wireless networks, like ensuring that the network and the platform are compatible? How do we manage costs related to that? And then, of course, rural coverage still lags behind, especially in broadband compared to urban centers. In terms of health systems, I still don't think we have any great idea about how we can reimburse health systems for the use of mHealth interventions. And that in part might be related to the fact that we have to maybe help health systems understand the value of mHealth interventions. And then, of course, how do we integrate those into electronic health records? In terms of practice, there's still a lack of knowledge about the existence and the use and the utility of mHealth interventions. There might be a misalignment between what we're actually developing and the target population. And I think we're trying to figure that out now. Often these interventions lack any sort of theory, which can be problematic. And then these applications tend to be very siloed. So NIH last year, or at the beginning of the year, put out a call where they're really trying to develop a more comprehensive and support a more comprehensive approach where we can combine a lot of mHealth intervention features to address the full spectrum of the HIV prevention and treatment continuum, so that we just don't continue to have these really siloed applications. And then in terms of research, there's certainly a need for high quality research to be conducted. We're still lacking a lot of efficacy trials, although the results of those trials should be coming out in the next 5 years or so. The technology, this is a perennial problem, right? The technology outstrips the pace of research. All of us know that the pace of research is exceedingly slow, and all of a sudden, once you get funded in 2 years, the technology you're using is kind of outdated. And then finally, greater access to, or understanding of access issues is important. So with that, I just want to say that back in 2012, so again, this is 8 years ago, these were the issues that were identified. And quite frankly, we have a lot of work to do in each of these areas. So there's still plenty of room for research in this area. I just want to thank the funders of the studies that we've been involved with, including NIDA and NIMH and NICHD. And I'll open it up for a discussion. Thank you.
Awesome. Thank you so much, Dr. Horvath. That was great. It was really cool to see also the actual iterations of your application.
Yeah, thank you.
And so, as you mentioned, we can open up discussion. Miley, I did see you made a comment, so I don't know whether or not you want to kind of like expand upon it.
Yeah, I'm happy to. So I just made a comment that I get really excited about these types of interventions because clearly, there are a lot of things that we just haven't really as a classic healthcare system been able to significantly impact like stigma. But I'm really pessimistic about coverage, you know, for these type of interventions, especially if we have to rely on our medical insurance. So I just made a comment that, you know, I think at least for now, these sorts of interventions would probably best be accepted by closed systems like Kaiser and the VA. You know, and especially if you can demonstrate that there's cost effectiveness and that customers or patients are satisfied with it. But I'm wondering if you had thoughts about how do we move these things into actually being implemented in the real world per se?
Yeah, I think it's an important question and a really challenging issue. I think part of what we need to be able to do, first of all, is demonstrate that these kinds of interventions are effective. And in fact, we just got done completing a systematic review of mHealth interventions for HIV testing. And quite frankly, there's just not that many efficacy trials yet reported. Now, again, I will say in the next 5 years, I think you're going to see a massive increase in the reporting of efficacy trials. So I think, you know, understandably, from an insurance point of view, they're not going to want to really fund something or invest a lot of resources in something that doesn't have the kind of rigorous evidence that will be needed to sort of implement this. So I think that certainly is the first step. The other thing that I think what we need to do is we need more research on how to implement mHealth interventions into community-based and clinic settings. I know that there's one large trial being conducted by Brian Mastansky where they got just a ton of money to basically look at how to scale up and implement their Keep It Up intervention in multiple cities in the US. So I think that the results of that will be really important. But I think one of the things that we need to be doing is in our grant proposals and studies that we're proposing is to start to incorporate some implementation research in terms of really talking with CBOs, general practitioners, HIV practitioners, public health administrators, and possibly then insurance company, right, executives about how we can best sort of integrate the interventions that we are developing into those systems, because not only will they want to see some evidence of it, but then we have to think about resources, right? Who is going to be running these interventions within those systems? Are you going to be sort of relying on the research team for companies to fund research teams to really monitor and run it, or are those going to be done internally? So I think there are a lot of challenges to that, but essentially we have to move it into more of an implementation science framework.
Does anyone else have any comments or questions? Okay, well, it's like 1 till 9, so that's great. And once again, you know, Dr. Horvath, thank you so much for joining us today.
Yeah.
We are very excited that San Diego State as well is now part of the CFAR network.
Great, wonderful. And thanks everybody again for showing up. I know exactly that from firsthand that having more Zoom meetings is not always great, but I appreciate everybody's attendance.
Awesome. Thank you so much. And then we'll see everyone again next week.
Thank you.
Thank you, everyone.